Well, hello everyone, and welcome to this.
Can you hear that? Can you see it? Yep. Okay.
Lecture on clinical metabolism. My name is Dr. Brian Skotko, and I'm a clinical fellow in genetics and metabolism today. And I'm very pleased to present this lecture to you. I want to just start by saying everything in clinical metabolism has a caveat, has an exception. So as we go throughout this lecture today, please put an asterisk next to everything I say and know that there are exceptions. But the point of this lecture is to get the basics, the fundamentals, so that when you learn the exceptions, you'll be able to apply them on top. Perhaps you're a clinical fellow like me viewing this lecture for the first time. The point of this lecture is really to give you the fundamentals, but it shouldn't replace medical knowledge. So if you're dealing with a patient, please always consult and check with your attending on proper patient care. Or perhaps you're a patient yourself, or you're a family member who's watching this lecture today, trying to understand the basics of metabolism. I want to remind you that this lecture doesn't substitute, of course, for medical care, and you should always consult your doctor before making any medical decisions or making any decisions about your health. But let's get started. We're going to talk about clinical metabolism, and as you can see, I've been a fellow, I have seen patients with this, and I have struggled with the basics of this, and I want to put together a basic map so that we could all understand this a little bit better. So metabolism in each of our cells in our body, in order for the cells to work, in order for the cells to function, they need to make ATP. And it's really all going to depend upon how do we get to getting the ATP. Well, we know that ATP ultimately has to come from the electron transport chain. And what we then have to figure out together is how do the different products, the different components of our food ultimately get to the electron transport chain in order to make the ATP? Well, as we might remember from biochemistry, everything has to go through the Krebs cycle. And so this is going to churn through that Krebs cycle, and then it's going to feed into the electron transport chain. Our food is basically composed of three basic elemental components. One is glucose. Another is fat. We have a nice fatty steak. Another part is protein. So as we eat our different foods, it's composed of the basic carbs, again the fat, and again the protein. And all of those three components have to get to the Krebs cycle in order to generate ATP, in order to give the energy that all our cells need to function. So how do we get from each one of these steps to the Krebs cycle? Well, let's take the path together. Glucose is going to be converted into pyruvate. And pyruvate is going to be converted into acetyl coenzyme A, which is then going to go into the Krebs cycle, then we're going to churn through the Krebs cycle, and then we can make ATP. So very simple from carbohydrates to ATP. Glucose, we could also get the source from a couple of other places. We have glycogen, which is a storage that could be converted to glucose, and then we go to that pathway. We also have galactose. Galactose gets broken down into glucose, and then it goes throughout the cycle. Galactose, as you might know, the food source is lactose. And then we also have fructose. Fructose gets broken down into glucose, and then we could get to ATP. And of course, the food source is sucrose. Now, that's how we get from carbohydrates to ATP. How do we break down the fat, the fatty parts that's part of all of our foods? Well, fat we know gets broken down into fatty acids. And the fatty acids get broken down into acetyl coenzyme A, and then we go through the Krebs cycle, and we've now made it to the ATP. A couple little offshoots. Acetyl coenzyme A could also form ketones, which we're going to talk about in a bit, and it could also form cholesterol, which is another important pathway in metabolism. And pyruvate also could go back and forth with lactate. I'm going to put these up there because we're going to talk about those in a second and why those might be clues on how the body is functioning in the particular patients that we're taking care of. All right, so we've now completed the pathway for carbohydrates and for fat. How do we get from protein to make ATP? Well, protein is going to be composed of and broken down into amino acids. And amino acids are going to go into organic acids. But in order to do so, amino acids also have to give off ammonia. Ammonia is very toxic to the body. We're going to talk about that in a sec. And the ammonia has to be recycled in order to be excreted. And that's going to go through our urea cycle. So that what could come off is urea, which is non-toxic in the body. So now we have protein broken down into amino acids going to organic acids. We're going to recycle that ammonia. Organic acids could either feed directly into the Krebs cycle, certain ones, or it could come back to our starting point, acetyl coenzyme A, to then go throughout the Krebs cycle and then make it to forming ATP. This is the basic map of metabolism. And I want to say that the majority, although not all of these different pathways will occur in the mitochondria, some do not, but for the point of this lecture, we're going to simplify and just assume that all of these are occurring in the mitochondria. There are some other genetic conditions and other metabolic conditions that occur outside of this in lysosome and peroxisomes and other organelles, but we're going to reserve those just for a brief comment at the end of this lecture. Now what we're going to do is we're going to test this system. We're going to say each one of these lines have, if we zoom in, lots of other different cofactors and enzymes, and the conditions that we're going to go through together can all be placed somewhere on this particular map. So let's proceed. So this is the map that I just drew, that we drew together, that's been more nicely drawn as we go throughout. And I want to start with one particular condition, and this condition we're going to start with is called Forbes disease. Now let's say that you're consulting and you have a patient call, or if you're a patient yourself and you say, I have Forbes disease. You say, well, the first step is to figure where on this map does it fall, if Forbes disease does fall. So you look it up and you realize that Forbes disease is a type of glycogen storage disorder. So as we look on the map, we see that this line right here, that is where the kink in the system is, going from glycogen down to glucose. So let's imagine, before we zoom in on this arrow right here, what does it mean to have Forbes disease or any of the glycogen storage disorders? So if someone is well, they're not currently sick, and they have Forbes disease, the body is going to say, okay, we're going to use some of the glucose that the person ate. When the glucose is used up, you become hypoglycemic. You don't have enough glucose. As many of you who are physicians who have taken care of patients, hypoglycemia can be a very dangerous condition. If you don't have enough glucose, it can result in illness and ultimately comatose and death if not treated immediately. So the body is going to be looking for glucose from the food. But when it runs out of the glucose from the food, the first step is going to be trying to drag some of the glucose, extracting it, breaking it down, if you will, from the glycogen. For someone who has a glycogen storage disorder, they can't do that, and immediately they become hypoglycemic. Before the body even thinks, maybe I should start breaking down my fat and breaking down my proteins, we're going to have some hypoglycemia. So individuals who are well with glycogen storage disorders need to constantly have a supply of glucose. And as you might know, babies, children who have glycogen storage disorders have to have routine continuous feeds. And overnight, sometimes they even need to get cornstarch, which is basically glucose that takes a long time to digest. So you put cornstarch in, you give the baby some cornstarch, and the body slowly will start to metabolize that and give a constant supply of glucose so they can make it throughout the evening, because they can't fast for a long amount of time. Now let's say you have someone with glycogen storage disorder who you've been seeing in clinic and you've been managing well, and now you're on call over the weekend and you get the phone call that someone with glycogen storage disorder is sick. So what does it mean to be sick? Well, we care, are you able, is the child able to take in food? So if the family calls and says, my child with glycogen storage disorder is not eating, they're throwing up, I think they have the flu, I think they have a bug, what should we do? Well, we know that that person needs glucose. So pretty soon, once they exhaust all glucose, and if they're not eating, they need to get into the clinic quickly, because we need to, in the emergency room, give form of glucose. And the type of glucose that we're giving is IV glucose. And you'll get very quickly used to this. We're going to give something called D10, which stands for the glucose in the IV form, usually 1/2 normal saline, and we're going to give it at 1.5 times maintenance. And what this means is that we're dripping in glucose, we're dripping in sugar at 1.5 times more than the body needs it, in order to tell that body, hey, we're giving you the glucose, you could still make your ATP, you don't have to become hypoglycemic. And that is going to be generally the emergency management for individuals with glycogen storage disorders. Well, why don't we zoom in to the glycogen storage disorders and learn a little bit more. So we're going to zoom in just like that. So glycogen storage disorders, as I promised you, each one of these arrows, we could zoom in and it has a whole other pathway that goes together. So let's zoom in a little bit more and say, how do we actually get from glycogen to glucose? So we're going to start with glycogen. And glycogen is then going to be converted into glucose 1P, which will then be converted into glucose 6P, which will then be converted into glucose. So as you can see, the first map we did together was highly simplified, but if you zoom in, you can see there's all sorts of certain subcomponents to it. Now if we look at this, the simple pathway, you already have the basics for all the other metabolic conditions that are glycogen storage disorders. So glycogen storage disorder, Forbes disease, is type 3, and that is a problem when glycogen comes down to glucose 6P. And that's going to be glycogen storage disorder type 3. So again, the one we're talking about today, the X is going to be right there, the kink in the system. But there's other different types of glycogen storage disorders. We have type 1A, we have type 1B. There is a type 2 called Pompe disease, and that is occurring in the lysosome, so it's kind of off this particular map and a little bit too complicated for the point of this lecture. Type 1A, they all have names. This is von Gerke disease. We talked about type 3. Type 4 is going to be going up. And type 4 is named Anderson disease. And then we have type 5, which is coming down again. And type 5 is McArdle disease. And then we have type 6, which is also coming down, and that HERS disease. And these occur in different sort of body places. So type 5 occurs in muscle, and type 6 occurs in the liver. So when you look at this basic structure, if you have someone with Forbes disease, you zoom in and you see that there's different places where the kinks can happen in the system, and this particular one is from glycogen to glucose 1P, but the management again is you got to make sure that they have enough glucose, and by getting enough glucose, we're giving it through diet, and when they become ill, we're going to supplement with lots of IV glucose. All right, so we've just done one part of our corridor. Now let's talk about another condition, galactosemia. What does galactosemia sound like? Well, galactosemia, very easy, probably from galactose to glucose, and so that X is going to be right there. So what do we do with these individuals who have galactosemia? Well, if they're well, they can and should be taking glucose, and they need to take enough glucose so they don't become hypoglycemic. But in this particular case, some of the buildup on this side, galactose problems, some of the galactose on this side, if it can't be converted, can actually cause some conditions, some medical issues, which we're going to talk about. So some of these, if built up, could have a toxic effect. So if these individuals are ill and you have someone who calls up when you're on call saying, my child has galactosemia, they're not eating, what should I do? You get them into the emergency room, and what's the treatment? Well, you know it, right? You want to give glucose because you want to tell the body, even if you can't get your galactose to the glucose, when you've run out of your glycogen to glucose, which would work in individuals with galactosemia, here is lots of glucose through the IV, and you're going to give the same D10, 1/2 normal saline at 1.5 times maintenance. But let's zoom in now, and let's see if we could together get galactose to glucose. So let's go back to the same chart right here, and we're going to try to get our galactose to our glucose. And very easily, we're going to have galactose goes to galactose 1P, which will then go to glucose 1P, which will then go to sorry, we're going to draw that arrow right here, glucose 1P, which will then go to glucose 6P, and then go to glucose. And so now we're going to talk about, well, where does galactosemia occur? So galactosemia has 3 different types. So from galactose to galactose 1P, you have GALK, which stands for the galactokinase. And from galactose 1P to glucose 1P, this arrow right here, you have GALT, which is galactose transferase, and then you also have a GAL, which is galactose epimerase. And the one classic galactosemia, if we were to talk about it, would have the X right there. And so if we have the X right there, we can get galactose to galactose 1P, but we can't get galactose 1P to glucose 1P. So we're going to have a buildup of galactose 1P. So what does this particularly mean? Well, let's talk about some factoids, some just individual facts that you should know that goes along with this different metabolic disorder. So individuals with classic galactosemia, classic GALT, have the individual mutation, Q188R, and they're homozygous for that. And that's classic galactosemia, which means that they have little to no working enzyme to take galactose 1P to glucose 1P. There are some individuals who actually have just a reduced amount of this enzyme, and it's enough to get. And that's called Duarte galactosemia, and you'll often see this as the most common mutation. This is the Duarte form. And while treatment varies based on where you are, and there is some controversy, many people feel that with Duarte galactosemia, there is enough GALT, there's enough of this enzyme so that you could get galactose 1P to glucose 1P, so that treatment is not needed. But for individuals with classic galactosemia, who again have no GALT, therefore you want to avoid the buildup of this, which could have toxic effects. What are some of those toxic effects? Well, very uniquely, one that you have to know is they can have E. coli sepsis. So if you have an individual come to the emergency room and they're hypotensive and they have galactosemia and they're very ill looking, they can have E. coli sepsis. And those of you who take care of individuals who are in the pediatric population know that while sepsis can occur, having E. coli as a type of sepsis is very rare, and that seems to go along with galactosemia. Why? We're not quite sure, but that is something that goes along specifically. The other thing is you have to monitor for coagulopathy. Individuals with galactosemia can have hemorrhages, and that goes along with the condition. And how are we generally going to treat this? Well, we want to avoid the buildup, so therefore let's not give lots of galactose. We know galactose in food comes in the form of lactose, so these individuals are on a lactose-free diet in order to avoid the galactose and avoiding the insult to the system. Even if you treat individuals with galactosemia, there still are some cognitive and some physical effects that go along with galactosemia. Just to name a few, these individuals will still have some challenges with speech. Sometimes there are learning disabilities. There is hypergonadic hypergonadism, and there's also could be some bone issues with osteoporosis and osteopenia, and they oftentimes need some extra help in school. So even by giving the lactose-free diet, we could see that the buildup, even if minimal, could cause some challenges. All right, we just went through two of our first metabolic conditions together, which really tested what I call the upper left corridor. Left doesn't really exist in your mitochondria, but this is how I view it, at least in my mind. We've tested glycogen to glucose, and we've also tested galactose to glucose. So now let's go back to our main chart here. And we know that glycogen to glucose, galactose to glucose, if those individuals are ill, we are going to be giving D10 because we want to tell the body, here's your glucose, even if you can't make it. There is one pathway on here where the answer, the correct treatment is not to give D10. Where would you not want to give glucose? Where would you not want to overload the system? Well, let's think. If there was an X right here, you couldn't get pyruvate to acetyl coenzyme A. If we were to give lots of glucose, we would just be feeding the system, feeding the kink and not getting it beyond. We would be throwing things into the fire here. So in this particular condition, which is called pyruvate dehydrogenase, we don't want to overload if individuals are sick with this particular condition because we would again be giving too much glucose and it can't get beyond that. So these individual patients with this particular condition, what is the treatment? What is the help for pyruvate dehydrogenase? You're going to be giving lots of ketones or a ketogenic diet because you want those ketones to come in to acetyl coenzyme A to then go throughout the Krebs cycle and make it to your ATP. So one thing to remember is if an individual with a metabolic condition that we're going to talk about today is generally ill, D10 1/2 normal saline at 1.5 times maintenance is generally the right treatment for emergency situations, with the exception of PDH, because then you're going to be blocked there anyway. Let's go on to another condition. Let's go on to something known as LCHAD. Well, what does LCHAD stand for? LCHAD stands for long chain long-chain hydroxyacyl dehydrogenase deficiency. Always need to look it up myself. But when we look at it and we say, well, where would LCHAD fall on this pathway? We realize it's a fatty acid oxidation disorder, and that's going to be an X right there. So let's talk about if the individuals who have LCHAD are well, and you just see them in clinic, and they're not sick at all, they're not throwing up, what could they do? Well, they could still break down glucose, go throughout the Krebs cycle and make ATP, just fine. They could break down glycogen, they could break down galactose, all of this machinery, if you will, and those pathways are all functioning well. But once the body runs out of glucose, once the body has used up glycogen, it then goes to its fat stores. This is the second stop, where the body is going to be breaking down the fat into fatty acids to make acetyl coenzyme A as a second way of generating energy. And when these individuals run out of their glucose stores and they have to go to their fat stores, then you run into the kink in the system, and then you start to have your issues. These individuals can break down the protein pathway, but that occurs later. So our body's going to try to break down glucose first, then fat, and then going for protein. So let's talk about these individuals. If they're ill, so if someone is ill with a fatty acid oxidation disorder, you want to make sure that the body doesn't start to go to break down this pathway, because then we're running into the kink. So they're ill, they're out there, they call you, my child's throwing up, my child is ill with a fatty acid oxidation disorder, what should I do? You know it. You want to give lots of glucose. And again, you're going to give that through D10, 1/2 normal saline, usually at 1.5 times maintenance. And why do we do that? We want to tell the body, keep on using this corridor. Keep on using this corridor. Don't even think to trying to break down fat as a source of energy, because once they start to do that, you're going to have some fatty acid oxidation disorders. Now let's talk about a couple of these other laboratory values here, which sometimes your attending might ask you to check, or you get called on, you want to say, well, what are we doing with ketones? What are we doing with lactate? What are we doing with pyruvate, right? So when would ketones be helpful? Well, ketones are generally helpful if someone has a working fatty acid oxidation pathway. So in you and I, who most likely do not have a fatty acid oxidation disorder, if this is working, once our body starts to utilize this corridor, if you get here, it's going to start to put some ketones in the urine. So if we fast overnight and we're not eating overnight and we're sleeping a long time, usually our body has run out of glucose and it's going to our fat stores, and when we wake up in the morning, if we check our urine, the ketones will be in there. And so this really is an indication that the body is starting to utilize this pathway. Ketones, an indication that the fatty acid oxidation pathway is being used. For individuals, however, with a fatty acid oxidation problem, they cannot get there, so they're not going to produce ketones in a large amount. And so these are not going to be reliable. And this is how you hear that individuals with hypoglycemia in a non-ketotic fashion, or non-ketotic hypoglycemia, means they used up this pathway, they can't make ketones, that means they must have a fatty acid oxidation disorder. So non-ketotic hypoglycemia means our issues must be here. Well, let's zoom in to this pathway right here and see if we can learn a little bit more together about fatty acid oxidation disorders. So we're going to zoom in right here. All right. So we need to get from fat to acetyl coenzyme A, because we know at that point that we're good to go throughout the Krebs cycle. And so this is going to be occurring in the mitochondria. And the mitochondria, we know, has two membranes. So we're going to draw it with two membranes. Now, if you're a carb, you have lots of carbons on it. And let me tell you, in order to get into the mitochondria, it's very specific. It only wants you if you have a carbon that's less than 20. So if you're C18, C16, that's the length. If you have more than 20 carbons, the mitochondria is not going to let you in. In order to get into the mitochondria, 20 or less. Well, where do you go? If you're 20 or more, you have to go to the peroxisomes first. And so when we talk about peroxisomal storage disorders, you go there, you get broken down to a C less than 20, and then the mitochondria is willing to let you in. In order to get let in, you have to go through 3 buses, and they all involve carnitine. So the first bus is going to be known as CPT1. And CPT1 stands for carnitine palmitoyl transferase 1. And then from there, you're going to go to the inner mitochondrial membrane, and you're going to go through the second bus, which is CACT. and that stands for carnitine acylcarnitine translocase. We love big, fancy, long words in metabolism. Then when you get through this, you're going to go through the third shuttle bus, which is CPT2. And this again stands for carnitine palmitoyl transferase type 2. So you have your little C, let's say 18. Carnitine is going to get you through the first bus, get you to the second bus, get you to the third bus, and then you're in. And when you come in, you're going to be, if you're starting off as a C18, a long chain fatty acid. From your long chain fatty acids, which really are more or less about C12 to C18, you're then going to go down and be broken down into a medium chain fatty acid. And that generally is going to be about C6 to C12, rough estimates here. And then you're going to be broken down into a, you guessed it, a short chain fatty acid. And then finally, and this is going to be C4 to C6. And then finally, what is C2? Well, C2, that is acetyl coenzyme A, our favorite, the final stop you need before you get throughout the Krebs cycle. So how does this work? Well, every time you have a C18 or a C16, wherever you're starting, you're going to peel off 2 every time. We're going to talk about how that happens. So you go from C18 to C16 to C14 to C12. And when you take off 2, what are you taking off? Well, each time you go throughout this pathway, you're taking off 2, and you're pulling off what's 2? Acetyl coenzyme A. So every time you're peeling off 2, you're forming more and more acetyl coenzyme A, which is feeding the system, which is then forming ATP. Well, in order to take off 2, each time you do that in the mitochondria, there are 4 enzymes that need to work. The first enzyme is acyl coenzyme A dehydrogenase. And the second is hydratase. The third is hydroxyacyl coenzyme A dehydrogenase. See, I wasn't lying when I said we love long words. All right. And the fourth is a thiolase. So what does this mean again? Every time you want to take off 2, you have to go through each of these 4 steps. And there's these 4 enzymes for the longs, there's these 4 enzymes for the mediums, and there's 4 enzymes for the shorts. So I said that the condition we're talking about is LCHAD, L-C-H-A-D-D. That's the one we were looking at. Well, now, if we just look at those letters, it decodes for us where we are. LC, long chain. That means we're up here in the long chain. It's not a medium chain. It's not a short chain. Long chain. HADD. Well, where is that? Hydroxyacyl dehydrogenase deficiency. It's this one. So these letters, if you decode them, will tell you it's a problem in the long chain and it's a problem in that third enzyme. What does it functionally mean? It means that you can't break down your long chains. You're stuck. They build up. They start to build up and they can't be broken down. And why is that an issue? Are they toxic? Well, they're not necessarily toxic in the sense like galactosemia we were talking about, but these long chains could start to build up. And where do they tend to build up? Well, they build up in different parts of your body, but for example, they could build up in your heart muscle. And that's how you get cardiomyopathy or a big heart in individuals with long chain fatty acids and with all the complications that come with that. We also know as a factoid to know that if a pregnant mother has HELP syndrome or hemolysis with elevated LFTs or liver function tests and low platelets, this is often an indication that she has a child with LCHAD or a long chain hydroxyacyl dehydrogenase deficiency. And this tends to go along with this as a different factoid to know. So let's go through a couple more. If you have someone with MCAD, MCAD, that would be a kink in this system here. Where does this come from? M, which stands for medium chain, of course. Now we have CAD, which stands for coenzyme A dehydrogenase. Okay? So medium chain acyl coenzyme A dehydrogenase. And so you see this is a problem in the medium chain with the first enzyme right here causing a kink in the system. And then, as you guessed it, there's SCAD, which would be short chain acyl coenzyme A dehydrogenase. So as you think about it, there's these 4 enzymes, and there's a long set, a medium set, and a short set. So there's about 4 times 3 or 12 different theoretical types of fatty acid oxidation disorders. But in reality, some of these are extremely rare and not known to exist, and some are more common than others. And as you go throughout your rotations, you'll learn which are more common than others. But your basic premise here is to decode the words, figure out where it is, and what enzyme it might particularly be. A couple other quick factoids that I think are important to know. If you are C8 or less, you get a free ride in. You don't have to go through all these shuttle buses. So C8, you get a free ride in. But C20, less than C20 to C8, you have to go through these carnitine pathways. Now, C8 is a form of MCT oil. And when would we give MCT oil? Well, we would give MCT oil if someone had LCHAD, right? Because if we gave MCT oil, even if this was blocked, we could shuttle bus that C8 in with bypassing the carnitine and therefore be able to utilize that system and make some acetyl coenzyme A without having to go and hit the kink in the LCHAD. But if someone had MCAD, or if they had a medium chain or a short chain fatty acid oxidation disorder, would we give MCT oil? No. Why? Because we would give it and we would still be hitting the X's. And so this is a convenient way, if you hear about MCT oil, when this could be given, and that's with long chain fatty acid oxidation disorders. Some other things that have been helpful with fatty acid oxidation disorders is to give carnitine. Why would we give carnitine? Well, carnitine is essential for the shuttle. So if we could drive perhaps more in, we could overload the system, deluge the system, and get things to go through. So that's where the premise for the carnitine comes from. There, just in a couple of minutes, we've been through fatty acid oxidation disorders. There is much more to know, but this will give you the basics for really understanding how to take care of individuals in this particular corridor of what I'm considering my map here. Let's move on to another condition, and this one we're going to do now is called OTC deficiency. OTC deficiency, which stands for ornithine transcarbamylase deficiency. Where is that in? Well, that is a problem right here in the urea cycle. We've now gone to this corridor over here. So let's think about it. If these individuals are well, they're visiting you in the clinic with OTC deficiency, can they break down glucose? They sure can. They can do everything in this pathway. Can they break down fat if they need to? Of course. And they will give you an indication they're going there because they're producing ketones. But if they start to break down protein, because it's been so long that they need a source of energy, that they start breaking down protein, or if they eat something that contains protein or a lot of protein, they're able to take the protein to the Krebs cycle. But in doing so, they're going to give off lots of ammonia that can't get recycled into urea. That's going to build up. And as we know, a very high ammonia could be very dangerous. And at a certain high level, it could cause comatose and it could cause death. So urea cycle disorders, if they are sick, if these individuals are sick, someone calls you and they said, I have a child with OTC or another urea cycle disorder, they haven't been eating, they've been throwing up, they have the flu, what should I do? Well, you want to get them into the emergency room very quickly because you want to give what? Of course, we know it. You want to give D10 1/2 normal saline at 1.5 times maintenance. Why? Because we're telling the body, don't even think about going to these other corridors. Here's your glucose and use your glucose. Now, we also want to take some urine because if they're starting to have ketones in their urine, if this is positive, we have an indication that the body has already gone to using the second pathway, which is like the yellow light saying that the body's soon going to take down this protein. When would you take down protein if the child's not eating? Well, you could start to naturally break down your muscle, which is protein, producing amino acids, or you need a certain amount of amino acids. There are essential amino acids. Even if you're not eating, even if you're getting enough glucose, your body's going to say, I need essential amino acids, and if not, I'm going to break down my muscles in order to find them. So we need to make sure individuals with urea cycle disorder get enough, but not too much. Enough so that the body doesn't naturally break down protein, but not too much that we're feeding the fire, we're feeding too much ammonia. Let's zoom in together and take a look at urea cycle disorders. So we're going to zoom in just like this. Let's see. Zoom in right here. We're going to put this up here just to remind us of this urea cycle disorder. All right, so now we're going to blow up that urea cycle. And we know that ammonia comes in, and it's going to go first to carbamyl phosphate. And then together with ornithine, this is going to be converted into citrulline. And citrulline is then going to go to arginosuccinate, which is going to bring in aspartate. This is then going to go to arginine, and off of this is going to come fumarate. And then this arginine is going to go to ornithine, and alas, finally we get what we were looking for, and that's urea. So this is taking ammonia, which is very toxic, and turning it by churning through this circle into urea. All right, let's just remind ourselves. Ornithine transcarbamylase, OTC deficiency, where does that occur? That occurs right here. And so essentially we have ammonia coming in, and it can't even the first step get through our urea cycle. And so what happens, the ammonia starts to build up right off the bat and can reach very dangerous levels. What happens when it reaches a very high level? Well, we're going to give a medicine that can basically convert this. If we can't get to urea, we'll convert this into two other products that could be excreted in the urine. But if it gets way too high, way too dangerous, then really the only way for treatment is dialysis, where we take the blood out, we cleanse it if we can as quickly as possible of ammonia, and we put the blood back in or take care of the child. So I said that there was a medicine that might be able to sponge up and convert some of that ammonia. And the name of that medicine is amino. And amino is actually a medicine that has two different components to it. So first, it's going to take ammonia to glycine. And then it's going to convert it to hippurate. And it's doing so through the first part of the medicine, which is sodium benzoate. And so sodium benzoate, the first part of aminol, is converting glycine into hippurate. Hippurate could then be excreted into the urine just as much as urea is. Now it's also going to take ammonia down another pathway, and it could go to glutamate, which could then go to glutamine. And then glutamine is then going to be converted into phenylacetyl glutamine. And this is done through the second part of the medicine, and that's sodium phenylacetate. So amminol is sodium benzoate and sodium phenylacetate together, the green, and that is basically your medicine, which is going to convert ammonia into hippurate, which is non-toxic and can be excreted into the urine, and phenylacetylglutamine, which is non-toxic and can be excreted in the urine. Some factoids that's worth knowing. So OTC deficiency, which is right here, is the only X-linked condition that's part of the urea cycle. So that obviously has ramifications, as you can imagine. It occurs more readily in boys. However, with skewed inactivation, girls with OTC deficiency can have some of the symptoms. Another factoid that is something that you should know is carbamyl phosphate can go on to form orotic acid. Why is this helpful? It's helpful because you could test for this in the blood. So if you check your blood for orotic acid in a child who is very ill, and this is sky high, then you realize for some reason this must be punning here because there's a block here. So sometimes in newborn infants that are very sick right away, high orotic acid, even before newborn screening and other testing comes back, is usually an indication you have a block early in the system. Well, that's OTC. Let me just put up the names of some other urea cycle disorders, and you can figure out what the basic process is for this. And you can look these up, and I'm sure you'll encounter them along the way. So here you have ASS, which stands for arginosuccinate acid synthetase, which converts citrulline into arginosuccinate. And then you have ASL, or some people call it ASA. And this one stands for arginosuccinate lyase, which then takes arginosuccinate to arginine. And then you have arginase, which then takes arginine to ornithine. And you could have missing enzymes. These are all enzymes that could be missing along the way. And again, it's just further down the pathway. It'll still kink it all up and lead to high ammonia, and they have some subtle different variations in terms of management. But urea cycle, the big thing is we want to give glucose if they're sick to avoid that natural protein breakdown or the hunger for different essential amino acids. But if the ammonia is high, our initial treatment is to convert it very quickly into other products in the urine or go to dialysis if it is way too high. All right, we've really explored a lot of different elements of this map already. The next one I would like to turn to is something that's called methylmalonic aciduria. So methylmalonic aciduria, what does that sound like? Well, methylmalonic acid is an organic acid, and so this is going to be a kink right in this pathway right here. Individuals who are well with methylmalonic acid, can they break down glucose? They sure can. Can they break down fatty acids? They sure can. Can they break down protein? Well, as we're going to discover together, they can break down certain amino acids, but certain amino acids will feed the fire. And so these are on a protein-restricted diet, making sure that they have enough essential amino acids, but not too much in order those that are going to feed right into the MMA pathway, which we're about to get to. These individuals who are sick, they call you, my child's throwing up, my child is not eating, what do? You want to, again, utilize this pathway. The easiest way to utilize it, which is working, is again with D10. So let's zoom in. Let's zoom into this pathway right here. And so we're going to be talking about the organic acid pathway. And there's lots of different organic acid pathways, and they're all a little bit different. But in terms of management, it's essentially the same. But let's talk about the MMA pathway. So in this one, it involves, we're going to talk about 3 amino acids. So leucine, isoleucine, and valine. So these are amino acids, and all of these are going to go down and be broken down by lots of different enzymes, by lots of different enzymes, by lots of different enzymes. And then isoleucine and valine ultimately form propionyl coenzyme A, which then gets converted into methylmalonyl coenzyme A, which then gets converted into succinyl coenzyme A. And succinyl coenzyme A, unlike acetyl coenzyme A, which is C2, succinyl coenzyme A is C3. Now, leucine and isoleucine will then be broken down, and these go right to acetyl coenzyme A. So methylmalonic acidemia is a organic aciduria where you have a block right there. So you could break down leucine, isoleucine, valine, you're doing fine, until you get to methylmalonyl coenzyme A, you can't break it down to succinyl coenzyme A. So what happens is you're going to have a buildup of methylmalonyl coenzyme A, and that could cause some medical issues that occur in individuals with MMA that you'll learn all about. But for the point of this lecture, we're not going to go into details about each one of these conditions. So MMA could sometimes be helped by giving cobalamin and certain cofactors, but again, you'll learn more about that in depth. Let's just take a look at this pathway for the sake of understanding amino acids and organic acids. So there's lots of different organic acidurias that occur on this pathway. If we were to have something that cuts all of those, an enzyme that isn't working in those pathways, this is called maple syrup urine disease. And as you would predict, these individuals can't break down leucine, isoleucine, and valine. So you say, well, the treatment should be make sure they're not taking protein or they don't have a formula or a diet that is rich in leucine, isoleucine, and valine. And that's the right answer. However, you can't eliminate the diet fully of these amino acids because the body needs them. They're essential. So you need to give enough, but not too much. And here's a factoid that you should know, is that leucine, of all of these three, this is the one that is toxic. And it has toxic effects if it is too high. So we want to make sure, again, you have enough, but if you have too much because there's a kink in the system, that leucine can build up and can cause lots of neurologic effects on individuals with these conditions. Some other organic acidurias, a kink later on down here is IVA, or isovaleric aciduria. Then you have MCC, which stands for 3-methylcrotonil coenzyme A deficiency, which is another organic aciduria. You then have MGA, which is methylglucoconol coenzyme A deficiency, also known as Barth syndrome. Again, all of these are just problems or missing enzymes in the breakdown of leucine, leading to the buildup of leucine. So again, you can learn more about the specifics, and you'll probably have patients here, but if you understand where they are, it's basically having to challenge breaking down leucine into acetyl coenzyme A. Some others that are worth knowing, I said right here is MMA. Another one is, if the kink was there, that's propionic aciduria. So propionic acidemia is another condition that you'll learn about. And again, you want to make sure that these individuals have diets that are lower in these amino acids, but again, they need enough. And when they're sick, you want to make sure that they're getting the glucose so we avoid natural protein breakdown. All right, so we just did an organic aciduria together. And we've really tested almost all the different spots on this map, but we're going to end with a condition that really is the bread and butter in terms of understanding metabolism, and it's where, in many ways, metabolism started with newborn screening, and this is PKU. So PKU, or phenylketonuria, what is that a problem with? Well, phenylalanine is an amino acid, and that is going to be a breakdown right here. So it's going to be a problem with the amino acid pathway. Individuals who are well with PKU, can they break down glucose? Can they break down fat? Of course. But what about proteins? Well, they have a problem with phenylalanine, so they need to have formulas or food that are phenylalanine free. And so that's going to be their treatment. But when they're sick, when they call you and they're throwing up, again, we don't want the natural protein breakdown. We don't want the body to search. So we're giving lots of glucose in order to avoid that pathway. Let's zoom in. All right, so phenylalanine. So PKU is the amino aciduria that we're talking about, amino acidopathy. And so this is a problem with phenylalanine. And it gets converted into another amino acid. Do you know which one? Tyrosine. And the enzyme that you need, all of these lines represent enzymes as we've been talking about, is phenylalanine hydroxylase, or as we abbreviate PAH. So if you have no PAH whatsoever, then you can convert phenylalanine to tyrosine, and you have an increase in phenylalanine, which is going to lead to some of the manifestations that come along, the clinical characteristics that come along with PKU. And some of those involve learning disabilities if the phenylalanine is too high for too long. Sometimes there is not complete absence of PAH, but a decreased amount. So how do we help it? How do we help convert the phenylalanine to tyrosine? Well, sometimes you will learn about cofactors, or in clinical metabolism, cofactors which will help convert. And in this case, phenylalanine can be converted to tyrosine through a cofactor known as BH4, or tetrahydrobiopterin. And BH4 is a cofactor that will work so long as you have some PAH available. And so in individuals with phenylalanine, you could do a genotype and know that some genotypes might be more amenable to this, or you could test the amount of PAH that is available. And sometimes giving supplemental tetrahydrobiopterin will convert phenylalanine to tyrosinemia. you'll learn that tetrahydrobiopterin is involved in some other pathways as well. So let's go back. We've been through a lot. We've taken an exploratory tour of lots of different parts of this metabolic map. We've done glycogen storage disorders. We've done a galactosemia. Here you could do on your own what would fructosemia or fructosuria look like if it was here. We've done PDH. Remember, we're not going to give D10 there because of the breakage there. We've looked at all the fatty acid oxidation disorders. We've looked at one amino acid acidopathy, but there's many others as well. We've looked at a couple of organic acidurias. There's many others as well. We've taken a tour of the urea cycle disorder, and we've learned the manifestations of that and the severe dangers of having increased ammonia there. All of these are going to be fed through the Krebs cycle to make ATP. And our general clinical guidelines are we want to help that individual make ATP during times of wellness and during times of sickness. And we're going to really try to give glucose in all but that one case we talked about to make sure that this pathway is active and so we don't start going to these pathways to break down. I want to mention I have a couple of different bonus items down here, and I said all of the things that we talked about for all essential purposes occur in the mitochondria. There are some exceptions. Some of these arrows are occurring in the cytosol, but these are the mitochondrial metabolic conditions that are primarily occur there. When individuals say they have a mitochondrial disorder, while these all occur in the mitochondria, that's specifically referring to problems in the electron transport chain. For the point of this lecture, we're not going to go into depth there, but you can imagine if individuals have problems there, they could get there, but they just can't make ATP at the last moment. And so those individuals with classic mitochondrial storage disorders have their own unique characteristics and their own unique ways of managing them. But outside, there's other organelles. So we have the mitochondria, but we also have lysosomes, we have peroxisomes, we have disorders of glycosylations, we have disorders of purines and pyrimidines, we have disorders of heavy metals, we have disorders like of copper and iron, and all of these don't occur in this pathway up here. And so what we talked about won't provide a pathway for those, but I want to mention that if you come across lysosomal, peroxisomal disorders of glycosylation or others, take a look at those, and they have their own lectures that are associated with those. But if you find something that's on this path and this map here, I hope it will be of help to you as you make your way throughout clinical metabolism. I just want to conclude by thanking you for joining me today. When I started my fellowship, clinical metabolism was all just a scary concept with lots of different arrows and pathways, but I found when I put them down and I thought about where it occurred in the system, it was very easy to navigate and a little bit more easy to understand. And you're going to learn lots more in depth as you go along. You'll learn lots of different enzymes. But what I would challenge you is as you get a patient with a particular condition, say, where on this pathway, this metabolic pathway, does that patient fit? Is they on this map or are they off this map? And if they're on this map, walk yourself through how best you would do treatment, because I think it will provide basics in terms of metabolism. So thank you for joining me, and good luck.